I'm going to ask you to do something today that most people have never done in their entire life. The next time you use the bathroom, don't just flush and walk away. Take 5 seconds and actually look at what came out. Because I promise you, what you see in that bowl is one of the most accurate, most immediate, most completely free diagnostic reports your body produces every single day. And almost everyone ignores it entirely. We live in an era where people are spending hundreds of dollars on wearable health trackers, on blood panels, on genetic tests trying to get a window into what's happening inside their body. And meanwhile, their gut is handing them a detailed status report on a daily basis, and they're flushing it away without a second glance. Today, I want to change that. I'm going to walk you through exactly what your poop's shape, consistency, color, and frequency are actually communicating about the state of your gut. And more importantly, what to do when those signals are telling you something is wrong. This is the guide I wish someone had handed me 20 years ago. Let's get into it. Before we get into what different types of poop mean, I need to give you the single most important piece of context about what poop actually is, because almost everyone has this wrong, and getting it right completely changes how you interpret what you see. Most people assume that poop is primarily undigested food, the leftover material your digestive system couldn't use. And yes, there is some of that in there, some undigested fiber, some food remnants. But here's what's remarkable. In a healthy adult, the majority of the dry mass of a stool is not food at all. It's bacteria. Living and recently deceased microorganisms from your gut microbiome. The vast, complex ecosystem of trillions of bacteria, fungi, and other microbes that live in your large intestine. This completely reframes what you're looking at. A healthy, well-formed stool is not just evidence that you digested your meal properly. It is evidence that your gut microbiome is thriving, that you have the right populations of bacteria in the right proportions, eating the right foods, and reproducing at the right rate. When your poop looks abnormal, the first question to ask is not, "What did I eat?" It's, "What is happening to my microbiome?" Because in most cases, that's where the real answer lives. Your large intestine, your colon, has two primary jobs that most people don't think about simultaneously. One, it absorbs water from the stool back into your body, which is why hydration status shows up so directly in stool consistency. Two, it is the primary residence of your gut microbiome, and the health of that ecosystem is reflected directly in the character of what comes out. Once you understand that, reading your poop becomes a genuinely useful skill, not just a quirky conversation topic. Type 1 hard, separate pellets, like small stones or rabbit droppings. This is the clearest possible signal of two things happening simultaneously. Your colon is absorbing too much water from your stool, meaning it's spending too long in transit, and your microbiome is starving. When beneficial gut bacteria don't have enough fermentable fiber to eat, their populations shrink. Their metabolic activity drops. They produce less of the short-chain fatty acids that keep the intestinal lining healthy and maintain the muscular contractions that move stool through the colon efficiently. The result is slow transit, excessive water absorption, and small, hard, difficult-to-pass pellets. We see this pattern most dramatically when people adopt very high-protein, very low-carbohydrate diets. The logic behind those diets is often that less food coming out means more is being absorbed, which sounds like efficiency. But the reality is that reduced stool volume in that context is not a sign of better digestion. It's a sign that the bacterial ecosystem has been significantly depopulated because the bacteria that make up the majority of a healthy stool have nothing to eat and nowhere to thrive. The fix here operates on two fronts. First, increase your intake of soluble, fermentable fiber, the kind your gut bacteria can actually metabolize. Not just any fiber, specifically prebiotic fiber, foods like leeks, garlic, onions, asparagus, unripe bananas, cooked and cooled legumes, and oats. Second, increase your fluid intake. Water is the most direct way to counteract the colon's overabsorption of moisture from stool. And for people who struggle with chronic constipation despite good fiber and fluid intake, magnesium, particularly magnesium citrate or magnesium oxide, at doses between 300 and 500 milligrams before bed, draws water into the colon osmotically and can produce a dramatic improvement within 24 to 48 hours. Type 2, lumpy, segmented, sausage-shaped, but with visible cracks and hard texture. This is a milder version of the same underlying pattern, slightly better hydration, slightly more bacterial activity, but still indicative of sluggish transit and insufficient microbial diversity. The key word here is diversity. One of the most important findings in modern microbiome research is that different species of gut bacteria have different dietary preferences. Certain bacteria thrive on inulin-type fructans, the prebiotics found in chicory, artichokes, and asparagus. Others preferentially ferment pectin, found in apples, citrus peel, and carrots. Others metabolize resistant starch from cooled grains and legumes. A microbiome that only receives one type of prebiotic fiber will support one dominant bacterial population at the expense of others. Variety in what you feed your gut is as important as the quantity. Ancient hunter-gatherer populations consumed an estimated 100 to 150 grams of fiber daily, but, crucially, it came from 50 to 150 different plant species per week, varying by season and geography. Rotating your prebiotic sources, not just taking more of one, is the practical application of this principle. Type 3. Smooth, sausage-shaped with small surface cracks. This is the target. Smooth transit, adequate hydration, good bacterial activity. If you're consistently producing this, your gut microbiome is in a healthy working state. Don't change anything. Type 4. Smooth, soft, like a snake or a log with a clean surface. Also excellent. This is arguably the gold standard, easy to pass, well-formed, reflecting a well-hydrated colon and a thriving, diverse microbiome. Minimal wiping required. When your bacterial populations are genuinely flourishing and you're providing them with the right substrates, the stool passes cleanly, with very little residue. If you've ever shifted your diet toward more prebiotic fiber and fermented foods, and noticed that wiping became almost unnecessary, that's not a coincidence. That's your microbiome doing its job at a high level. Type 5. Soft blobs with clear-cut edges, passed easily. Starting to move toward the loose end of the spectrum. Often indicates mildly accelerated transit. The stool is spending less time in the colon than ideal, so less water is absorbed. This can reflect mild irritation of the gut lining from dietary triggers. Common culprits include raw cruciferous vegetables, high lectin foods, or simply eating too quickly and too much at one sitting. For many people, switching from raw to thoroughly cooked vegetables resolves this. The heat breaks down the plant defense compounds that can irritate the colon wall directly. Type 6. Mushy, fluffy pieces with ragged edges. Frequent urgency. This is where the gut is clearly under stress. The lining of the colon is being irritated either by a specific food component, by a microbial imbalance, or by an inflammatory process. Lectins, plant proteins found in high concentrations in raw grains, legumes, and nightshade vegetables, are among the most common dietary triggers for this pattern in my clinical experience. They can directly interact with the cells lining the intestinal wall, disrupting the tight junction proteins that keep the gut barrier intact and triggering an immune response that manifests as chronic, soft, urgent, ragged stools. The first dietary intervention is an elimination of the most common irritants for 2 to 3 weeks: raw grains, undercooked legumes, raw nightshades. If significant improvement follows, reintroduce one food group at a time to identify the specific trigger. Cooking these foods at high heat or pressure cooking legumes dramatically reduces lectin content and often resolves the problem completely. Type 7. Entirely liquid, watery, with no solid pieces. Diarrhea. The colon has essentially surrendered its water absorption function, either because transit is so fast that no absorption can occur, or because the colon lining is actively secreting fluid to flush out an irritant or pathogen. Travel-related diarrhea caused by exposure to unfamiliar bacterial strains, poorly handled food, or contaminated water is the most common trigger. In most cases, these resolve within 3 to 14 days without pharmaceutical intervention. Bismuth subsalicylate, the active ingredient in Pepto-Bismol, is one of the most evidence-backed over-the-counter options for this. It has antimicrobial properties, reduces intestinal inflammation, and coats the gut wall. Natural compounds, including berberine, oregano oil, and garlic extract, have documented antimicrobial activity against the most common travel pathogens and are worth having in your kit. Oral rehydration is critical, not just water, but electrolytes, because the fluid losses in diarrhea carry sodium, potassium, and chloride with them. A homemade version is simply water with a pinch of salt and a small amount of honey or fruit juice. If diarrhea persists beyond 2 weeks, contains blood, or is accompanied by fever, medical evaluation is not optional. There is a category of intestinal infection that does not respond to natural interventions and requires targeted antibiotic therapy. Brown, the normal baseline. The brown color of healthy stool comes from bilirubin, a breakdown product of old red blood cells that the liver processes and excretes into bile. Bile is released into the small intestine to help digest fats, and as it passes through the gut and is metabolized by bacteria, it transforms chemically into the pigment compounds that give stool its characteristic brown color. Different shades of brown, from light tan to very dark brown, are all within the normal range and primarily reflect diet, hydration, and transit time. Green, usually diet-driven, occasionally a transit signal. The most common cause of green stool is a high intake of chlorophyll-rich foods, leafy greens, green juices, spirulina, chlorella. When eaten raw and in large quantities, these can pass their pigment through the digestive system faster than bacteria can break it down into brown bilirubin metabolites. Green stool from dietary chlorophyll is completely benign. However, persistently green stool without a clear dietary explanation, particularly in the context of type 6 or 7 consistency, can indicate that transit through the small intestine is too rapid and bile is not being fully converted. This is worth monitoring if it continues beyond a dietary change. Yellow, a fat absorption signal worth paying attention to. Yellow, greasy, or foul-smelling stool, particularly when it floats, typically indicates that dietary fat is not being properly absorbed. The fat passes through the intestinal system largely intact, giving the stool a pale, yellowish, oily appearance. This steatorrhea, the medical term for fat in stool, can result from insufficient bile production by the liver, insufficient bile release from the gallbladder, or insufficient lipase production by the pancreas. People who dramatically increase fat intake on high-fat diets sometimes see this temporarily as their digestive enzyme production catches up. But yellow, floating stool that is not explained by dietary change should be evaluated. Pancreatic insufficiency is one cause, and celiac disease, which damages the small intestinal lining and impairs fat absorption, is another. Pale, clay-colored, or white. This is urgent. A stool that is pale gray, clay-colored, or nearly white means that bilirubin is absent. Bilirubin is absent when bile cannot reach the intestine, and bile cannot reach the intestine when the bile duct is blocked. Bile duct obstruction has a range of causes, some of which are serious. Gallstones are the most common, but in some cases the obstruction reflects a mass, including pancreatic cancer, which can compress the bile duct as it grows. Clay-colored stool, especially when accompanied by yellowing of the eyes or skin, dark urine, or abdominal pain, is a medical emergency. Do not wait to see if it resolves on its own. Contact your doctor the same day. Bright red. Almost always hemorrhoids, but confirm it. Bright red blood on the toilet paper or in the toilet bowl after a bowel movement is most often caused by hemorrhoids, dilated blood vessels in the lower rectum or anal canal that bleed when stressed during passage of stool. This is extremely common, especially in people with chronic constipation or straining. It is not immediately dangerous, but it does indicate that the pressure on those vessels is high enough to cause rupture, which is itself a signal to address the underlying constipation. However, any rectal bleeding that is not clearly from an external source, particularly in anyone over 40, should prompt a conversation with your doctor. Colorectal cancer can bleed, and early detection is everything. Dark, maroon, or tarry black. Do not wait. Dark, sticky, tar-like stool with a distinctly foul odor almost always indicates bleeding somewhere higher in the digestive tract, the stomach or upper small intestine. Blood that has traveled through a significant length of intestine is broken down by bacteria into dark compounds that give the stool this characteristic appearance. This is a medical emergency. If you have never taken iron supplements or large quantities of Pepto-Bismol, both of which can temporarily darken stool, and your stool appears black and tarry, seek emergency care. Bleeding ulcers are the most common cause and can be life-threatening if not treated promptly. Diversify your prebiotic fiber sources. Don't just increase one. The single most impactful change most people can make for gut health is not eating more of one fiber source, it's eating more types of fiber from more plant sources. Aim for at least 30 different plant foods per week. This sounds ambitious until you realize that herbs, spices, seeds, and nuts all count. Adding ground flaxseed to your morning routine, rotating between different vegetables each week, eating a variety of legumes, these are all meaningful contributions to microbial diversity. The goal is to feed not just the bacteria you have in abundance, but the rarer, specialized populations that exist in smaller numbers and require specific substrates to thrive. Add fermented foods daily, not just occasionally. Fermented foods: yogurt, kefir, sauerkraut, kimchi, miso, tempeh, kombucha, and even vinegar and traditionally fermented coffee and tea provide postbiotic compounds that your gut bacteria need to activate their beneficial functions. Prebiotic fiber provides the raw material. Fermented foods provide the metabolic signals. Research from Stanford has shown that a diet high in fermented foods increases microbial diversity and reduces markers of inflammation more effectively than a high-fiber diet alone over a short period. Both together are the target. A simple, practical habit. Add a tablespoon of apple cider vinegar to a glass of water before one meal daily and incorporate at least one fermented food into your daily eating, even if it's just a spoonful of yogurt or a few bites of sauerkraut. Identify and remove your personal gut irritants. Not every gut-disrupting food causes the same problem in every person. The most commonly problematic categories are gluten-containing grains, raw, high-lectin foods like undercooked beans and raw nightshades, artificial sweeteners, particularly sucralose and aspartame, which have been shown to disrupt the composition of the gut microbiome, and raw cruciferous vegetables in people who are sensitive to their glucosinolate content. An elimination and reintroduction protocol, removing all suspected triggers for 3 weeks and then adding them back one at a time, is the most reliable way to identify your personal irritants without expensive testing. What resolves when the food is gone and returns when it comes back is your answer. Time your eating and manage your hydration deliberately. The colon is most active in the morning, driven by something called the gastrocolic reflex, the peristaltic wave that the colon produces in response to food entering the stomach after an overnight fast. This is why most people feel the urge to have a bowel movement in the morning. Eating breakfast, even something small, activates this reflex and trains your colon to empty on a consistent schedule. People who routinely skip breakfast and eat their first meal in the early afternoon often find that their bowel rhythms become erratic or sluggish. For hydration, the standard guidance of 8 glasses of water per day remains reasonable, but the timing matters. Drinking a full glass of water on waking, before the first meal, helps hydrate the colon before transit begins. Coffee, contrary to popular belief, is not dehydrating at normal intake levels, and it happens to be a potent gastrocolic reflex activator, which is why so many people associate their morning coffee with their morning bowel movement. That's not coincidence. Consider magnesium if everything else is in place and constipation persists. Magnesium is involved in over 300 enzymatic processes in the body, including the regulation of smooth muscle contraction in the intestinal wall. Deficiency, which is extraordinarily common in modern populations due to soil depletion and low vegetable intake, can manifest as chronic constipation that doesn't respond well to fiber or fluid increases. Magnesium citrate, or magnesium glycinate, at 300 to 400 milligrams, taken at night, is safe for most adults and can produce measurable improvement in stool consistency and frequency within days. It also improves sleep quality and reduces nighttime muscle cramping, two common concurrent complaints in people who are magnesium deficient. Here is what I want you to take away from everything we just covered. Your gut is not a passive processing system. It is a living, dynamic ecosystem home to trillions of microorganisms that are in constant communication with your immune system, your brain, your hormonal system, and your metabolism. And the single most accessible window into the health of that ecosystem is something you produce every single day and have historically given zero attention to. The shape tells you about transit speed and microbial abundance. The consistency tells you about hydration and gut wall integrity. The color tells you about bile production, fat absorption, and whether there is bleeding somewhere in the system. And the frequency tells you about the overall rhythm of your digestive function. None of these require a lab. None of these require a prescription. They just require the willingness to take 5 seconds and look before you flush. If what you saw today prompted you to recognize a pattern you hadn't connected before, the chronic pellet-type stool that started when you cut carbohydrates drastically, the persistent softness that correlates with eating raw salads, the floating stools you've normalized as your baseline, take that recognition seriously. These are not trivial inconveniences. They are signals from a system that is trying to tell you something, in the clearest language it has available. The protocol is not complicated. Diversify your fiber sources across at least 30 plant foods per week. Add a fermented food to your daily eating. Identify and eliminate your personal gut irritants. Hydrate consistently and eat breakfast to activate your morning gastrocolic reflex. And if chronic constipation is still an issue after all of that, add magnesium at night and give it 2 weeks before concluding it isn't working. Do those things consistently, and the daily report card your gut is handing you will look dramatically different within 4 to 6 weeks. I have watched this happen with patient after patient, not because of dramatic interventions, but because they finally started paying attention to the information that was always available to them. Start paying attention. Your gut has been trying to talk to you for years.